So first of all, COVID-19, very quickly, you all know it's a coronavirus, and it's called a novel coronavirus, which means it's new. And why is that important? It's important because we don't have any immunity to it. That's the critical part of novel coronavirus, COVID-19. Without immunity, if we don't put up proper safeguards, it will sweep through the entire globe. That's what happens with new viruses. That's why this one is drawing so much attention as opposed to, say, the flu, which will affect 400 million people globally this year and kill 1 out of 1,000 people. However, a novel coronavirus, which we have no immunization for, it will take 6 to 9 months at least to form a solid immunization plan. There's no way we're going to get that here in the acute phase of the disease, and that's why it scares people so much. Coronavirus 19, COVID, that's the COV, disease, that's the pneumonia in the lungs, 19 for 2019. Started in Wuhan, China, as you all know, and did spread globally. As of today, we have 438,749 cases with 19,675 deaths. In the United States, we have 55,245 cases confirmed and 802 deaths. And Hawaii, as of this morning, we will get a new number at about noon. We have 90 cases that are confirmed. And as of this moment, either 0 or 1 death, because the individual that did pass away, and blessings to his family and prayers for them, it has been retested and the test came back negative. So I think that that is sufficient to say. But I do know of 3 individuals, all of whom are actually on the younger side, surprisingly, that are in the intensive care unit and are at jeopardy of dying, people that I know about as a clinician. So this is a very, very serious situation. Let me cut to the chase. We absolutely must isolate at home for this period of time. Under any and all circumstances, we have to social distance like you're doing very, very professionally there in the chambers. But isolating at home, with the exception of essential necessary services, for instance, getting food or getting health care if you're in a crisis, and maybe a very small other set of reasons to go out, if people isolate at home, the spread will come down very quickly. The reason for that is that we only can defeat these viruses where we have no immunity if we do not allow ourselves to spread them through the droplets, through coughing, sneezing on people. We'll talk more about this. And then it burns out. The cases that are out there, and there are certainly more than 90, we've only begun to test aggressively about 10 days ago in the community, as you know. We brought testing up in Hilo a couple days ago. A testing site was in Kona that my team set up. Only because we hadn't tested did we have no cases that we had confirmed. The cases were there, and we're now finding them. But the truth is, we still have a much smaller number of cases than many other states, and that is a blessing. That is the way we could actually suppress this, and that's why the order to home quarantine, as painful as it is, economically, from a business standpoint, we'll talk about the bailouts that are necessary, and you'll lead that. Because of the necessity to stop it and kill this virus, for which we still have a chance, we should do this. Now, I know it's very difficult. It's a very difficult decision, and I will not criticize anybody from Big Island, okay? It is a big challenge, although you'll ask me penetrating questions, and I will be candid and open with you about my best recommendations. But by stopping its spread and doing it through April 30th, we will be able to hopefully mitigate the crisis that has hit other countries like Italy or states like New York. Now, let me get into a little bit of nitty gritty because I know that these numbers are helpful to share. The big picture on the state, we have a shortage of healthcare providers and healthcare facilities, as you know, and we are working constantly to try to improve that, but it's hard. This Big Island is even in a worse situation, as is Maui and Kauai. We have a greater shortage of healthcare providers than even the rest of the state. State has about a 22% shortage of healthcare providers across all disciplines. Big Island has a 40% shortage of healthcare providers. And as to beds for hospitals, because when COVID-19 does start affecting people and sending them to the hospital, about 5 out of every 100 people that get COVID-19 end up in serious condition and need serious hospital support. It will flood the hospitals and overwhelm them just like that if we have a big surge. So let me get to some details. Statewide, we have 3,031 licensed hospital beds. As of 2 days ago, and we get these numbers updated very frequently, we were at 65% occupancy. That meant that 1,970 beds were occupied out of our 3,031. We also are capable of surging our capacity, and this is very good news for you, Chair, to a number of 437 additional beds statewide for intensive care purposes. On the Big Island, Hilo Hospital is particularly well positioned. They're able to surge their capacity by 67. And that's why I went and toured Hilo Hospital and Kona Hospital to make sure we have extra surge capacity. We have 328 ICU beds as of this moment, 204 negative pressure isolation rooms. That's to keep people quarantined and so they can't spread virus if they've got it. And somewhere between 431 and 560 ventilators, depending on what they put up operationally. But we can get up to 560 without difficulty. And I say this because that means, once again, we had 1,061 additional beds available, plus the 437 if we had to surge. So about 1,500 additional hospital beds. But here's the rub. If we allowed COVID-19 to roll right through the state of Hawaii, and we got, say, 40%, let me just use that as an example, 40% of all of our people getting sick, 40% of 1.4 million, you can do the math very easily. That's about 500,000 people, correct? So when 500,000 people suddenly get sick, and of that, like I said earlier, 5% end up needing severe hospitalization, that is a large number. 10% would be 50,000. 5% is 25,000 people needing serious care in the critical care capacity with ICU beds. Now, in the very best of circumstances, we only have 328 ICU beds and some surge capacity. So if we went up a peak and down a peak really fast, like happened in Italy, and some large part of those 25,000 people or more surged to the hospital, we would have to choose who to give care to, whether some people would get ICU beds and some wouldn't. Some get ventilators, some don't. Some get that breathing tube. That's what I'm speaking about. So the necessary choice to slow down the virus, to do home quarantine, total isolation, is to basically either knock the thing out so it goes boom, like this, like it did in some places like South Korea, or you just slowly go up and slowly come down. And when you slowly go up, we have the capacity to surge in Hilo and Kona and on Kauai and Oahu, and then you slowly come down. We bring the military to bear as needed, and we keep people alive. Because when kupuna get it, it is a serious problem. Age 75 to 79, the mortality rate is 8%. 8% of people will die, as opposed to the baseline of 3% globally will die. And when people are over 80 years old, the mortality rate goes to 14.4%, which is catastrophically bad. And if you have a big surge like this, you're already hearing some states say that they will not put people on ventilators if they're over 80, over 70. They're now saying over age 60 in some places because their survival rate is so low and the likelihood of coming off the ventilator is almost zero. So that is the basis of the reason to both socially isolate, be very serious about home quarantine, to destroy this thing before it becomes a big spike. And then we get out and begin to resume and essentially jolt, like we do when we have to give someone in cardiac arrest, a jolt. We jolt the economy back when the time is right, when we're not worried about spread, when the virus has died down very significantly. We jolt the economy back, and the stimulus plans and all of the support for small business and people is, after keeping them alive with their rent and small amounts of money, standing up hospitals as needed, then we begin the much larger process, which we will rely on legislators like your body to decide where do we best invest our money? What do we re-stand up? What do we reopen? How do we support those who went through great economic pains and so on? That is the overview that I basically have for you. I don't want to be overly alarmist. I will say this. We had to stop the cruise ships because they were spreading infection terribly. That's why I called for that. We had to do some community spread and set up private screening because we had only set up about 35 to 40 total tests from the Department of Health. That was a failure. But now we've done many, many thousands of tests, and we're doing many thousands more. And then finally, the call, I believe it was about a Thursday ago, which you guys acted on with unbelievable speed. And I can't tell you how both stunned and respected that move was, how stunning it was for me and how much I respected it, to actually make that judgment call with no delay was not just an act of courage, but it was also bold leadership that will save lives. So those things, though we've never had to do them before, were necessary because we had the actual real-time examples of what would happen if we didn't do this. So that's why I'm continuing on with my role, and I'm speaking with FEMA, General Hara, whoever needs my help, and we can speak to all the other processes. But that is the overview. And I'm hopeful that in the coming days, now that we have a lot of tests in the field, we will get a much better picture. We won't be going blind at this problem. We'll get a better picture of where the disease is in our state, what we can do, where we have to surge extra capacity, how long it's going to take for us to get out of this. So again, thank you. I'm sorry for such a long intro, but I thought if I laid out those basics, it might alleviate the necessity for some other standard questions that are coming from perhaps the social media community or even some of you legislators.
We're not going to have any active cases unless we are actually doing the testing, because we won't have the information. Yeah. And I appreciate the fact that you've been pushing so hard to get that. Making good decisions can only be done with having the data to make those decisions. Now, on your on the surveillance testing, I guess I'll use that term, your thoughts on that, please, and how do we support pushing that initiative forward?
Well, I do have some concerns about surveillance testing, not because it's not a good premise. It really is very important. Let me refresh people if they're coming to this new, other than you've done great research already, but surveillance testing, that's kind of like the background testing that you do so that you can see in a society during an outbreak how many cases are kind of just out there. Now, unfortunately, the CDC had a lot of glitches when they first sent the tests over. So no fault of our own Department of Health on that one. There were some definite problems. Their tests were broken, the kits were broken, the reagent wasn't working, and so on. So we went through that period. That's ancient history. Once we finally emerged capable of testing, they took a few tests. And by the time they got to a couple hundred tests of flu, because we first test for flu, it's very common, right? So if people get the test for flu and they're positive for flu, that's it. You do not have COVID-19. That is all. You could debate that a tiny amount, but you're not going to have two of these major viruses at the same time. You might have one after the other, but you don't have them at the same time. That's not how viruses work. They took the baseline of the flu test and then retested those to see if there was COVID-19 underlying. It's a good thing to do because you do want to find out whether there's background disease. But in this case, and they all came back negative, it's not particularly helpful. And let me tell you why. I'm going to do a graphic for everybody, okay? Forgive the graphic nature of this. Imagine this is a swab, okay? This pen. And I am a doc and I do a test for the flu. Most healthcare providers will do this. Are you guys ready? Your LG is about to pick some books, all right? You do this. You put it in there and you go around the nose and then you test the thing, okay? And then it says, okay, flu, no flu. Now, if I instead want to do a test for COVID-19, I have to go, and some of you have had this, I got to go deep in there. I'm not doing this myself now. You got to go deep in there to the nasopharynx, to the back. And then you get 10 seconds, and then you come out, and then you can test successfully for COVID-19. So many of those tests are going to be inconclusive because you got the booger test and you're checking for where flu may be, or you have the very serious test that people do. And there's a lot of variability when those tests are taken. Therefore, the only real way to get a background in society was to do what we did, which was to go very widely into Hilo, into Kona, into the depths of Honolulu, into Maui, and to do comprehensive tests. And that's what we're now seeing. So it's pretty important that we do it right. We now have a much better idea. And my overall belief is we have to conserve our tests and be smart about it. But anyone who is symptomatic, we should be testing because we need to know how many cases are in different regions, how many little kids are cakey or spreading this thing around, how many of our kupuna are at risk, and also where we are regionally. Because perhaps if we have a surge of potential cases in, say, Maui, we need more intensive care unit capacity there and more ICU beds and ventilators. Perhaps we are lucky and we have very little disease on Big Island. Then we know we don't have to drop another 100,000 masks. We need to make the best decisions possible. And we can only do that based on the sentinel testing done right and also good comprehensive screening everywhere.